London, an iconic city where history, culture, and innovation converge, was the perfect backdrop for this year's European Society of Cardiology conference. In this episode, I'm thrilled to bring you the most valuable outcome of the gathering, the latest updates that will change our practice of cardiology. While London is famous for its timeless landmarks, today we're offering something that's more precious, the groundbreaking guidelines and clinical trial results that emerged from the conference. This episode will ensure that you will stay ahead of the curve without spending hours going through hundreds of pages. We'll break down the most impactful clinical trials and summarize the 4 new guidelines, keeping you informed of the most important advancements in the field.
Welcome to Cardio Buzz, your one-stop shop for all things cardiology. We bring you the news, groundbreaking research, and the most recent guidelines. We interview the experts in the field and try to answer the most difficult questions of everyday practice.
Out of 26 late-breaking clinical trials, I've selected the 10 most impactful that could influence our daily clinical decisions. For cardiogenic shock, mechanical circulatory support has always been a difficult question. In a recent meta-analysis, mechanical circulatory support did not improve the 6-month survival. Sad news. But the good news that in nearly 600 patients with STEMI and low risk of hypoxic brain injury, mechanical circulatory support was shown to be life-saving with 23% relative risk reduction. This highlights the critical importance of patient selection for these devices. The sweet spot seems to be in those who are at high risk but did not develop hypoxic brain injury. For acute MI, aggressive cholesterol lowering at the time of hospitalization results in better clinical outcomes at 1 year when compared with the classic stepwise treatment strategy, according to a new analysis from the Sweetheart trial. So not only the lower the better, but there is also a timing aspect. Those who were given high-intensity statin plus ezetimibe reached the target earlier and had 20% less events compared to those who used the stepwise approach. For patients after myocardial infarction, it seems that beta blockers still have a role. The ABYSS trial revealed potential risks in stopping beta blockers for stable patients with left ventricular ejection fraction over 40% after a STEMI. Discontinuing beta blockers led to increased hospitalizations, higher blood pressure, and no improvement in quality of life. For patients with stable coronary disease, PCI makes a difference. The 10-year follow-up data from the FAME2 trial has strengthened the case for PCI, showing that PCI outperformed optimal medical therapy alone. For heart failure with mildly reduced or preserved ejection fraction, finerenone, which is a revolutionary treatment for diabetic chronic kidney disease, is making waves in cardiology. New data from the FIND-ARTS trial showed its benefits in heart failure with preserved and mildly reduced ejection fraction. This could establish finerenone as a pillar for heart failure and could, in the future, mark the end of the road for spironolactone as a core heart failure therapy. For patients receiving GRASP blocker and going for non-cardiac surgery, halting or continuing GRASP blockers before non-cardiac surgery in the STOP or NOT trial showed no significant difference in outcomes. For patients with mitral insufficiency and heart failure, edge-to-edge mitral repair continues to gain ground. The ReShape-HF2 trial brought positive results for patients with moderate to severe mitral insufficiency and heart failure. Meanwhile, the Matterhorn trial demonstrated that transcatheter edge-to-edge repair is just as effective as surgical mitral repair for secondary severe mitral incompetence. For patients with severe aortic stenosis and concomitant coronary disease, the Notion 3 trial showed that PCI combined with TAVI is better than medical therapy with TAVI alone for treating significant coronary stenosis in severe aortic stenosis patients. PCI done before TAVI is probably the way to go for a comprehensive treatment when aortic stenosis is combined with coronary disease. For women with severe aortic stenosis, TAVI is the winner. The RIA trial found that TAVI with the SAPIEN valve was superior to surgical replacement in women. This is the first dedicated randomized trial for TAVI in female patients. New guidelines. This year, the European Society of Cardiology celebrates 30 years of guidelines. The ESC just released 4 brand new guidelines covering essential topics that are at the heart of our daily practice. Hypertension, chronic coronary disease, atrial fibrillation, peripheral/aortic diseases. There are lots of changes in these 4 sets of guidelines that reflect newer concepts, newer cutoffs, some medications being demoted and others got upgraded. We won't dive deep into all of them today. That's what the coming weeks are for. But today, we'll be highlighting the most crucial points that will immediately impact your practice. Keep in mind that medicine is always evolving. And remember, guidelines are just that, guides, not laws set in stone. They need to be adapted to local resources and aligned with patient values. And yes, it's okay to disagree with guidelines if you have a sound justification. So let's take them one by one. Now let's dive into the latest guidelines on hypertension and elevated blood pressure. Right from the title, it's clear that there is a shift in how blood pressure is classified into not elevated, elevated, and hypertension. For years, there's been debate over where to draw the line between what's normal and abnormal blood pressure. In these guidelines, a systolic blood pressure of 120 mm mercury and a diastolic pressure of 70 mm mercury mark the boundary between elevated and not elevated. Office blood pressure measurements remain the primary gateway to diagnosing hypertension, with 8 clearly defined steps that highlight the importance of correctly measuring this simple but often mishandled variable. Meanwhile, home and ambulatory blood pressure monitoring continue to be essential and are given a Class 1 recommendation for all hypertensive patients. For home measurements, there are 5 key recommendations on the type of the device to use, timing of the measurement, and the cutoff points. Ambulatory monitoring has 4 similar steps. The recommended routine tests for the initial evaluation of a patient with elevated blood pressure or hypertension remain unchanged. However, the million-dollar question is, what should be done for those with elevated blood pressure who are not yet classified as hypertensive, those whose systolic blood pressure ranges between 120 and less than 140? The answer is based on solid evidence. If these patients have established cardiovascular disease, risk modifiers, or a cardiovascular risk greater than 10%, then they should be treated. The treatment here begins with a 3-month period of lifestyle modification. If blood pressure remains at or above 130/80 afterwards, medication should be introduced, usually immunotherapy. This approach may have economic implications, and it would give the impression that we are over-treating patients, but the aim here is clear: to prevent heart failure, myocardial infarction, and stroke more effectively. Guidance on physical exercise has been refined to include specific recommendations on the frequency and the intensity of aerobic and resistance training. Other lifestyle modifications remain largely unchanged, except for a Class 2A recommendation to increase potassium intake by 0.5 to 1 gram per day, either through potassium-rich salt or by consuming more vegetables and fruits. There haven't been dramatic changes in the recommended drug classes since the last guidelines. The initial choice remains a combination of ACE inhibitors or ARBs with a calcium channel antagonist or a diuretic, followed by escalation as needed. Unlike the European Society of Hypertension, these guidelines do not include beta blockers as a first-line option, except in specific and compelling situations. This highlights the flexible nature of guidelines and the importance of applying them judiciously in everyday practice. As for the blood pressure targets, the ESC now recommends a target systolic pressure of 120 to 129 mm mercury, a diastolic target of 70 to 79 mm mercury. However, there are cautions for certain groups: patients with symptomatic orthostatic hypotension, elderly patients 85 and above, those with moderate to severe frailty, or those with a limited life expectancy. The benefits of aggressive blood pressure lowering may be less clear in these cases, and these patients are less likely to tolerate intensive drug therapy. Remember, guidelines are not a substitute for clinical judgment that should be tailored to individual patients. Renal denervation is not recommended as a routine treatment. It gets a weak recommendation for patients with resistant hypertension. The guidelines also feature updated sections on managing hypertension in frail patients, pregnancy, isolated systolic hypertension, and hypertensive emergencies. These topics, we'll explore them in more detail in future episodes. The latest guidelines on chronic coronary artery disease emphasize the various phases of coronary disease, including the different mechanisms and phenotypes of microvascular disease, which is now a significant contributor to the spectrum of coronary disease alongside the epicardial disease. The central theme in the new guidelines is the stepwise approach to evaluate and manage coronary disease. There are 4 steps. Step 1 and 2 include the initial evaluation. For the first time, there is a clear, structured approach to to evaluating individuals with suspected coronary disease. The initial 2 steps focus on a thorough history, physical examination, ECG, echocardiography, and biomarkers to determine the likelihood of obstructive coronary disease. A significant update is the risk factor weighted clinical likelihood model, which now has a Class 1A recommendation because it outperforms other scores to predict coronary stenosis. This model combines a symptom score based on the type of the chest pain or the dyspnea with a number of risk factors to estimate the clinical likelihood of coronary artery disease. This clinical estimate can be further refined into a higher risk if the ECG, echo, exercise test, or CT scan show significant abnormalities. The risk can be refined and reclassified as lower if the coronary artery calcium score is 0. Step 3 is diagnosis confirmation and risk estimation. This is done using CT scan, non-invasive tests, or invasive angiography, depending on the clinical likelihood established in the first 2 steps. Stress echo and CT scans are particularly valuable in defining the likelihood of obstructive coronary disease after positive and negative results. For the first time, microvascular disease is given detailed phenotypic classification based on the constellation of findings from fractional flow reserve, index of microcirculatory resistance, coronary flow reserve, and acetylcholine testing. Step 4 is the treatment. And in addition to lifestyle modification, we have medical therapies that either aim at relieving angina or improving the prognosis. For medications that relieve angina, there is a shift from the old first-line and second-line therapies to a more tailored strategy based on the patient's hemodynamics and comorbidities. Ranolazine and nitrates now have a Class 2A recommendation. Ivabradine gets a Class 2A recommendation for patients with angina and left ventricular dysfunction, but it was demoted to Class 3 as an add-on treatment for patients with angina and no heart failure and with an ejection fraction of more than 40%. There's a new algorithm that guides therapy based on the phenotype of INOCA, ischemia with no obstructive coronary arteries, or ANOCA, angina with no obstructive coronary arteries. Medical therapy for prognosis management is now grouped into 4 classes: antithrombotics, lipid-lowering, anti-obesity, and anti-inflammatory. For antithrombotic therapy, dual antiplatelet is recommended up to 6 months, can be shortened 1 to 3 months in patients at high bleeding risk. Single antiplatelet therapy becomes the standard for extended use, with clopidogrel Plavix earning a Class 1A recommendation as an alternative to aspirin monotherapy based on the results of several trials. There are also updates in lipid-lowering therapies. The LDL goal is less than 1.4 millimole or less than 55 milligram per deciliter with a 50% reduction from baseline for all patients. Bempedoic acid now is strongly recommended for statin-intolerant patients. Anti-inflammatory therapies are also gaining attention. Colchicine got a Class 2A recommendation to reduce the risk of MI, stroke, and repeat revascularization backed by the findings from the COLCOT and the LODO-CO2 trials. Anti-obesity agents, semaglutide also gets a Class 2A recommendation for obese patients with a body mass index 27 or more with coronary disease even without diabetes because it was shown to reduce death, MI, and stroke. As for revascularization, interventionists will feel happier now. Revascularization is highlighted as more effective than optimal medical therapy alone, based on recent meta-analysis of randomized controlled trials with extended follow-ups. Adding revascularization to guideline-directed medical therapy significantly reduced cardiac mortality and spontaneous MI. The benefit of revascularization was most evident in patients with multivessel coronary disease, and the ischemia extended trial confirmed the 2.2% absolute decrease in cardiovascular mortality favoring the initial invasive strategy. Should we go for PCI or coronary bypass? PCI has moved up in the recommendations compared to coronary bypass graft for unprotected left main and for multivessel disease. For isolated left main disease, bypass retains the Class 1A recommendation for all anatomical subsets, whereas PCI is Class 1A for low complexity, syntax score less than 22, and it gets Class 2A for higher syntax scores. For multivessel disease in non-diabetics, CABG remains Class 1A in all subsets, but PCI is Class 2A in high surgical risk patients if feasible. In multivessel disease in diabetics, again bypass is Class 1A across all anatomical subsets, whereas PCI is class 1A for those with low intermediate anatomical complexity, reflecting evidence from recent meta-analysis that showed improved outcomes with PCI, especially when guided by imaging and advanced interventional bifurcation techniques. We will be reviewing in more detail the ESC guidelines on coronary artery disease in the coming weeks. Peripheral arterial and aortic disease. Here we find a groundbreaking guideline document that combines peripheral arterial disease with aortic disease for the first time, emphasizing a holistic, multidisciplinary approach to vascular health. Let's start with lower limb arterial disease. Screening is recommended for high-risk groups using the ankle brachial index, ABI, with a cutoff of 0.90. The toe brachial index and transcutaneous oxygen pressure are highlighted for patients with suspected medial calcification that can falsely elevate the ankle brachial index. Critical limb ischemia is defined by the ankle pressure of less than 50 mm mercury or a toe pressure of less than 30 mm mercury. The grading of severity remains consistent with the Fontaine, Rutherford, and Wi-Fi classifications. The treatment goals now focus on reducing MACE and MAIL. MACE are major adverse cardiac events, which include death, myocardial infarction, hospitalization, coronary revascularization, where MAIL stands for major adverse limb events, and these include amputation, critical limb ischemia, lower limb revascularization. How is that achieved? This is achieved through a comprehensive approach involving lifestyle modification, control of cardiovascular risk factors, and antithrombotic therapy. The blood pressure targets are, systolic blood pressure targets are 120 to 129 mm mercury using the preferred agents RAS blockers. LDL targets below 1.5 millimole achieved with a high intensity statin, adding ezetimibe or PCSK9 inhibitors if the target is not achieved. Bempedoic acid is now highly recommended for statin intolerant patients. Antithrombotic therapy is now more standardized. Low risk patients get a single agent. High-risk patients get aspirin plus rivaroxaban 2.5 twice. Patients who need anticoagulation for other reasons, oral anticoagulation alone is enough. After endovascular interventions, dual antiplatelet therapy for 1 to 3 months, then modifying based on the bleeding risk and the thrombotic risk. Supervised exercise training, either at home or at hospital, is emphasized for its numerous benefits, except in patients with critical limb ischemia. The guidelines provide extensive details on the frequency, duration, and intensity of this supervised exercise program. For critical limb ischemia, revascularization is better done in specialized centers with a multidisciplinary team. The priority is for surgical autologous vein bypass graft unless the patient is at high surgical risk, in which case endovascular approaches are preferred. Other key areas covered in the guidelines are the renal arteries, where there is a comprehensive management algorithm, including screening, Doppler ultrasound, optimal medical management for hypertension, and the indications for revascularization based on being unilateral or bilateral. For mesenteric ischemia, CT scans are recommended for imaging. Endovascular intervention is preferred for symptomatic patients over surgical intervention. For subclavian disease, symptomatic patients may be treated surgical or endovascular, while some asymptomatic patients will still benefit from revascularization. These include patients with a Lima graft, a hemodialysis shunt, or patients planning bypass graft. These three subsets should be revascularized even if asymptomatic. For aortic disease, this is where the guidelines truly revolutionized the concept. There is now a standardized nomenclature for the aorta into 11 segments, following the recommendations of the Vascular Surgery Society and the Thoracic Surgery Society to unify reporting and intervention approaches. The new cutoffs for intervention for aneurysmal disease do not just look into the diameter, but they look into other morphological aspects like root versus ascending phenotype, aortic length, the expansion rate, and genetic factors. For thoracic aneurysms, intervention thresholds were lowered from 5.5 centimeters and set at 5.0 or 5.2 millimeter, depending on the surgical risk and the morphology. Abdominal aneurysms, recommended thresholds are 55 millimeter in men, 50 millimeter in women for fusiform aneurysms, 45 millimeters for saccular aneurysms. Acute aortic syndromes are classified by timing and severity from hyperacute 24 hours, acute 14 days, subacute up to 90 days, and chronic beyond 90 days. The new classification, TEM classification, complements the classic Stanford-DeBakey system. T stands for the type, A or B, E is the entry point, and M is malperfusion of vital organs. The medical management of acute aortic syndromes involves controlling the heart rate and the blood pressure as well as pain relief. For traumatic aortic injuries, they are graded from 1 to 4, with TVAR or open repair indicated for grades 2 to 4. For type A aneurysms, of course, surgery is recommended. For complicated type B aneurysms, surgery or endovascular repair is indicated. For uncomplicated type B dissections, optimal medical therapy can be sufficient unless the patient has one or more of the high-risk features enlisted in the guidelines. Here, intervention or open repair will be recommended. For genetic aortic diseases, there is a new chapter that covers conditions like Marfan syndrome, Turner syndrome, Loeys-Dietz syndrome, with detailed screening and intervention guidelines based on genetic factors and the phenotypes. There's a lot to unpack in these particular guidelines, so we'll be exploring these topics in greater depth over the coming episodes. Now let's delve into the atrial fibrillation new guidelines. In these guidelines, the care scheme serves as the central framework for managing atrial fibrillation, emphasizing 4 key areas. CARE is C-A-R-E. The C in CARE stands for comorbidities and risk factors. It's now recognized that addressing comorbidities and risk factors is critical to prevent the development, the progression, and the recurrence of atrial fibrillation, as well as in avoiding cardiovascular events. Key risk factors that need to be tackled include hypertension, heart failure, obesity, alcohol use, and exercise, all of which are highlighted as cornerstones in managing the atrial fibrillation journey. The A in CARE stands for avoiding stroke. Here, initiating anticoagulation therapy is recommended regardless of the AFib's temporal pattern. Gender has been removed from the thrombotic risk scoring, so now the SHAD-VASc score is simplified into the SHAD-VA score, with gender being considered a risk modifier rather than a primary risk factor. This change in removing the gender also accommodates the growing complexity related to gender diversity, such as transgender individuals. A SHAD-VA score of 2 indicates a clear need for anticoagulation, while a SHAD-VA score of 1 is a class 2 indication. Bleeding scores should not dictate the decision to start anticoagulation. Instead, we should focus on managing bleeding risk factors, including uncontrolled hypertension, alcohol use, labile INR, unnecessary antiplatelets, or non-steroidal anti-inflammatory drug use. Direct oral anticoagulants are preferred over vitamin K antagonists, except in patients with mechanical heart valves or mitral stenosis. If vitamin K antagonists are used, we should aim for an INR of 2 to 3 in at least 70% of the time. Antiplatelets should generally be avoided, and if necessary for a coronary or a vascular event, they should not extend beyond 12 months from that event. The R in CARE stands for relief of symptoms, rate and rhythm control. Separate pathways exist for first diagnosed, paroxysmal, persistent, and permanent atrial fibrillation. They are all built on the CARE scheme. We begin with rate control for all AFib individuals, followed by rhythm control for suitable patients. A point of safety: for AFib lasting for more than 24 hours, we do not cardiovert unless we do a transesophageal echo first, or we give 3 weeks of anticoagulation. Catheter ablation is now a class 1 recommendation in patients with paroxysmal atrial fibrillation to relieve symptoms, prevent recurrence, and avoid disease progression. Catheter ablation is also class 1 recommendation for persistent AF after failure of antiarrhythmic drugs. The choice of antiarrhythmic medication should be tailored to the presence of any underlying heart disease. The E in CARE stands for evaluation and dynamic assessment. This involves screening high-risk individuals using various tools, continuing anticoagulation after ablation, and continuing anticoagulation in patients with triggered atrial fibrillation. There's now even a version of this guidelines dedicated to be used just by patients. So the CARE pathway offers a structured and a dynamic approach to AFib management, focusing on comprehensive risk assessment, prevention of stroke, symptom relief, and continuous patient evaluation.
If you enjoyed this episode, don't forget to hit the like button, share, and leave a comment. Make sure to subscribe to the channel and hit the notification bell so you never miss an update. Stay tuned for the full summary of all the new guidelines in the coming episodes. Thanks for your support. See you all soon.